Hello class, my name is Rochelle Vinson and I will be attacking the cons. The continued need for restraint and seclusion exists because there is a high probability that physical injury and harm will be a consequence of not proceeding with restraints and seclusions. So I have two examples here of how restraint and seclusions were necessary to save clients from severely harming or causing death to themselves. These examples come from a paper written in 2014 by Sachs and Walton. There was a suicidal patient with a diagnosis of anorexia nervosa and borderline personality disorder. She had to be restrained for 12 days because of successful repeated attempts to pull out a nasogastric tube, which increased the risk of esophageal puncture every time they would try to put it back in, and she was resisting. So after the staff were able to establish a therapeutic relationship with her, the suicidal behaviors decreased. But that just shows where her life was in danger and they had to use restraints for her. Another example, a man with schizophrenia repeatedly swallowed small objects. He was able to escape surveillance and find small objects to swallow. Because of this, he had to have 3 emergency gastroscopies. So seclusion for several days was necessary to prevent him from harming himself even more. And after a medication change, this behavior stopped completely. And these examples show how restraints and seclusions were required to prevent serious self-injury after less restrictive means failed and until a solution to the dangerous behavior was established. A need exists for seclusion restraint when a person poses a serious and imminent risk and cannot make sound decisions for themselves. Sachs and Walton pose possible consequences in the reduction in the usage of restraints and seclusion. It's a possibility that there would be increases in over-medication to manage the aggressive behaviors instead of using the restraints or seclusions. Disruption to the entire environment because of one individual's behavior. Here's an example of a woman who was admitted for treatment of mania. On her first night in the hospital, she sat in the center lounge shouting and singing. When staff intervened by using relaxation techniques in the comfort room and offering PRN medications, she lectured them about being a prisoner in the hospital. At a community meeting after this event, fellow patients charged the staff with negligence for avoiding seclusion and allowing the patient to humiliate herself in front of other patients and for disrupting the atmosphere of the hospital. So by not using seclusion in this case, there was a conflict between the patient's autonomy and other patients in a therapeutic environment. Another example of disturbing the atmosphere when they have excessive intrusiveness with other patients or their visitors, or displaying frightening behavior and sexual advances or exposure. So this could also be something that would disrupt the atmosphere. So another outcome of possibly reducing or eliminating the use of seclusions and restraints are that hospitals could find ways to refuse to admit patients who require high levels of restraints and seclusions, which could result in these patients being sent to public hospitals, jails, or prisons instead. Ruth said that there's psychological and emotional trauma possible. Is it ethical? Putting this person in a situation resulting in additional fear and loss of control. The Wisconsin Department of Public Instruction Guidelines for Appropriate Use of Seclusion and Restraint in Special Education Programs says the immediate goals of seclusion and physical restraint are to diffuse the dangerous situation, protect the student and others from injury, and regain a safe, controlled, productive learning environment. Buren and Wolfberg, 2014, from the text Learners on the Autism Spectrum, says that crisis management is a short-term solution for the immediate management of potentially dangerous behavior that threatens the safety of themselves or others and are needed because we cannot allow students to harm themselves or others. So additional fear and loss of control would be to not use a restraint or seclusion, because that's used when we want to prevent the escalation of further damage to themselves or others. So it's also not meant to teach students pro-social responses nor teach appropriate alternative behaviors. Ruth also said that seclusions and restraints will cause a recipient to form an aversion to the environment, but a student harming themselves or others would clearly cause psychological damage and an aversion to the environment for both parties. The staff, the clients, patients, and they're meant to prevent more extreme outcomes than the actual restraint or seclusion would produce. Obviously, the restraint or seclusion is going to produce some adverse effects, but the reason the intervention is used is to prevent a more intense and high magnitude event from taking place. In regards to the negative impact on relationships between clients and the staff, there was a study in 2011 by Janet Hagopian and Buelu that analyzed the heart rate and self-injury of a person with autism with and without restraints. It was found that when some form of restraint was applied, the heart rate of the individual was close to or within resting heart rate, so they were calm. And when the restraint was removed or signaled to be removed, the heart rate of this individual with autism significantly increased within a short amount of time. And when the restraint was reapplied, the heart rate decreased and returned to normal resting range within minutes of being back in the restraint. So this shows an instance where the individual was comforted by, being in this restraint. Another thing that was brought up was that it is not prohibited in schools. So while restraints and seclusion may not be completely prohibited in schools, some states have prohibited certain aspects of these procedures. An article published on a website called ProPublica analyzed each state based on how closely they followed key elements outlined in certain reform bills and the U.S. Department of Education guidance suggestions. It was found that 20 states prohibited prone restraints in schools. Mechanical restraints were prohibited in 18 states. The U.S. Department of Education has published in May 2012 a resource document on restraint and seclusion to guide each state on the use of seclusion restraints on students with disabilities. And this was also published to encourage the states to review current policies and guidelines in schools. This resource document analyzed the incidences of seclusion and restraints in Florida. This data showed from 2010 to 2017 the number of incidents of seclusion and restraints decreased every school year since the districts began reporting these incidents in 2010. This data can be viewed on the slide following this one, and it will show you that seclusion incidents decreased from 4,637 in 2010 to 1,351 in 2017, and restraint incidents also dropped from 10,683 in 2010 to 8,770 in 2017. So it's pretty significant numbers. Another point that was brought up was that poor training leads to misuse of restraints and seclusion. Sachs and Walton, in their paper in 2014, wrote about the history of changing attitudes towards seclusion and restraints, and they cited a review done by Bush and Shore in 2000 where they concluded that environmental related variables such as location, staffing and staff philosophy were more important than patient characteristics in determining rates of seclusion and restraint. So it's up to the establishment to create a culture within the company that promotes the proper use of seclusion and restraints. So this is showing that it's, up to the company to create an atmosphere and culture that promotes, the proper use of these techniques. And that's all I have. Thank you.